to introduce our speakers. So Nancy, Rob and Lindsay, are you there? Can you unmute and turn your cameras on, please?
Hello, I'm here.
Yeah, hi, I'm here, Tamsin, and Lynn is, I think, also joining us.
I'm here, yes.
Brilliant. So I think let's start by introductions, then a brief talk from each of you, and then please, to the audience, pop any questions and comments in the chat and we'll pick them up in the panel. So Rob, would you like to introduce yourself?
Yes, thanks very much, Tamsin and Kathy, Anna, for setting this up. And it's a bit of a change of tack where we're going to zoom right into the sort of tip of the iceberg, if you like, from the massive sort of population-based challenges that we face to the individual clinician challenges. And for the next half an hour or so, what we are setting out to do is just to sort of whet your appetite and give you a bit of insight into what we do on a day-to-day basis in our various roles in the hospital. So I'm a paediatric gastroenterologist and the service lead for a gastroenterology, hepatology and nutrition team. And I was just going to illustrate some of the patients' challenges that we face in our day-to-day lives before handing on to Nancy and Lynn to tell you a bit more about their roles. So I'm going to try and share my screen. I've just got a few pictures to share with you. Can you see that?
It's coming through.
Yeah, so really it's a sort of clinical perspective of food as nutrition and therapy. And the first and most important thing to say, if I can make it work, is that it's very much a team challenge. So that although I'm a lead of the team, there's many more important individuals in our team that include a whole bunch of important therapists, and not least, and I put the family at the top of this because of course, for the vast majority of nutrition and treatment, we need siblings, parents, grandparents to help us work together to provide this. But there are key and critical players in the team around the child to support nutrition. And I'm going to talk through a few aspects of this, and I know Lynn will add to this. But safe to say that in our team we have 2, sometimes 3, sometimes 1 dietitian that is instrumental in delivering care on the wards and in outpatients. Some nutrition nurses who are involved with inpatient care and care of children at home on intravenous nutrition, a speech therapist as part of a complex feeding clinic, pharmacist to support our intravenous nutrition program, a couple of psychologists who are key in the endless ramifications of food and behavior, and I'll talk a bit more about that. And we try and conduct that with a clinical view as the gastroenterologists. So I've broken down 3 slides or 4 slides with a bit of a focus on each of that area, which is how our clinical service broadly functions around food and nutrition. So nutrition support, I guess, is the predominant effort that we're involved in, right from neonates needing supplemental nutrition by tube, and that's either a temporary tube on the top left, a more permanent abdominal tube, and the predominant children that require this is whose gut isn't fully working, and that might be short gut that needs some additional support while it grows, and the advantage in infancy, of course, is that your gut length can substantially improve and grow, and you can adapt to manage your enteral nutrition, your oral nutrition to support you, although that might require several weeks and months in hospital. And there are a small number of children, 14 or 15 in our region, who are fed intravenously, so through a line into a large vessel, that require nutritional support, which they're now able to have at home, go to school and thrive without needing to take all of their nutrition by mouth. Lynn and her team spend a lot of time supporting children with specialist formulas, and there is a whole range of conditions that require nutrition as therapy. It's a complicated and ever-evolving field where you really do need expert advice from infancy right through to children and young adults who in many cases will need nutritional support and advice for many years. There is a group of children, and I was just going to talk about two that really see nutrition and food as treatment, although we don't see them very often anymore. Children presenting with celiac disease, typically a wasting condition because of gluten, had and have their lives revolutionized by a gluten-free diet, something that once the diagnosis is made, relies entirely on support from families and advice through able and competent dietitians. At the same time, fortunately, we don't see many children like this anymore. Children with Crohn's disease, quite clearly there is an obvious nutritional component to this, and we continue to use exclusive nutritional treatments to heal the gut lining, to switch off inflammation and restore weight gain and growth in some of these children with Crohn's disease. And again, you need a specialist team around a child to support that sort of treatment. My last slide is one that probably consumes most of our time and effort, and is really around the huge range of behavioral consequences of eating, feeding, and managing different food products. And that's both psychological, psychiatric, and gastroenterological. The management of behavior around food ranges from those children on the autistic spectrum who increasingly are recognized as having behavioral food aversive challenges, through irritable bowel and stress and anxiety induced gut symptoms, food intolerances that aren't well documented and can be extraordinarily difficult to manage and lead to all sorts of significant impacts on day-to-day life, as well as, of course, support of eating disorders children, where I think we really stand a great opportunity with our Children's Hospital proposition of getting together and providing the best possible care for children through that pathway. So there is an enormous overlap that we live every day within our clinical service between behavior, psychological, and food and nutrition. And I'm really excited at making that overlap all the more tangible by working with mental health partners. So that's all I was going to say. I'm happy to hand over to Lynn. I think next you're going to say a few words about your role and wider challenges.
Thank you, Rob, and the floor is yours, Lynn.
Thank you. My apologies, I don't have some slides, so I'm afraid you're going to have to look at my face for the next few minutes. My name is Lynn Radbone. I'm the principal paediatric dietitian at Addenbrooke, at least for the next 6 hours, because I finish in post this afternoon. And what I would like to take the next 10 minutes to do is to introduce you to the role of the acute unit dietitian within the hospital environment, and to demonstrate how we approach the subject of food and nutrition in the management of the child in the hospital environment. I think actually to understand how the dietetic team themselves would use food with care, it's first a need to understand the role food and nutrition plays in a hospital stay for a child, and how in particular this aligns with a range of local and national standards and specifications which we have to adhere to for the provision of food in a hospital. We've heard quite eloquently this morning so far how nutrition impacts on both mental and physical health for children, and we are for understanding how under and over nutrition are a risk for all children within an environment. Our overall aim as a service, as a dietetic service, is therefore has to be to promote healthy eating habits for children, both for their current and for their future health and well-being. However, it is absolutely imperative that a balanced approach is taken to this in the acute setting, especially when a child's length of stay is short. The average length of stay at the moment for a child within CUH is around about 2 days. Unlike adults who have a relatively narrow range of nutritional requirements, children have a very wide range of requirements, and these are dictated by their age, by their weight, by their underlying diagnosis, or for the reason for their admission. On all of the physical wards that we're envisaging within the Cambridge Children's, any food provision model is going to have to accommodate the need of all childhood ranges. That could be from the teenager who wants to eat incessantly, to the panicky 5-year-old, to the newly weaned baby, or even the preterm baby whose gut isn't mature enough to tolerate milk and yet has a per kilo energy requirement equivalent to that of the Tour de France cyclist on an uphill climb. To make these challenges even more complicated, these nutrition requirements have to be delivered within a framework that has to be set out to meet both local and national standards and specifications for food delivery in hospital. And these are produced by the Department of Health, by the National Scientific Advisory Committee, the Caroline Walker Trust, and from NHS estates. So bearing that in mind, I think in order to describe the nutritional care of in the acute setting, it's useful to divide the children's cohorts up into 4 broad categories. Firstly, I'd like to talk about the nutritionally otherwise well child. Secondly, the child who has the need to conform to some kind of therapeutic dietary regime. The child who has a requirement for an altered nutrient provision. And fourthly, the child who is unable to meet their own requirements through normal eating and drinking. For the nutritionally otherwise well child, a stay in hospital is a break of routine. This can be disruptive to normal eating patterns and can often result in a child needing to be coaxed to eat and tempted to eat. Although there are clearly real benefits of trying to introduce a healthy diet in this environment, especially to those children that are at risk of obesity, attempts to impose, and I'll put in inverted commas, a healthy diet on a sick child can actually be futile and sometimes counterproductive, as it can lead to inadequate intake, prolonged length of stay, and prolonged ill health. The primary objective, therefore, of the dietetic service for this group of children is to ensure that children are able to eat sufficient food to meet their nutritional requirements as soon as possible, either after their admission, their surgery, or during treatment. And at risk of being shot down in flames, I'm going back into Burger King, I would actually say if we were faced with a child who was struggling to eat and meet their nutritional requirements through any attempts that we have tried to support them and their family to introduce foods that they're familiar with, if the one thing they will eat is a Burger King, then I would let them have it. So shoot me down if you wish. For the second category of children I'd like to talk about is those who have a need to conform to a therapeutic regime. Rob has alluded to a couple of these already. There are a wide range of therapeutic regimes which we use for dietary manipulation for children, either as a sole treatment for disease or for the management of a single or multiple symptoms. Some of these can be simple or multiple food exclusions for the management of food allergies or intolerances, the gluten-free diets alluded to already for the management of celiac disease, ketogenic therapy, which is a patient-specific calculated diet for the management of drug-resistant epilepsy in children, where protein and carbohydrates are severely restricted and fat provides 80% of a child's prescribed energy intake. Can you imagine what that's like? They live on cream and butter. carbohydrate counted menus for children with type 1 diabetes, fat counted menus for children who require enzyme replacements with cystic fibrosis, clean neutropenic diets for immunocompromised children on the cancer wards, or patient-specific macronutrient modified diets that incorporate a wide range of specialist prescribed therapeutic foods for the management of inherited metabolic diseases. Any food delivery model chosen for the Cambridge Children's Hospital has to be able to provide a menu with a range of food options that will meet the requirements of these and many other therapeutic regimes. It needs to have standardized recipes and a facility for a clear and rapid communication between catering and dietetic services regarding changes in recipes or products, and the composition of products that may actually affect the products or meals' ability and suitability to meet the needs of therapeutics at specific diets. The third group is the child who has a requirement for altered nutrient intake or nutrient provision. In the acute hospital environment, these are groups of children whose nutritional needs exceed those that can be delivered by a conventional 3-meal-a-day service. And these children also tend to be those that have a length of stay that's over 7 days. There are 3 ways to describe these groups of children. Firstly, the child who has the increased nutritional requirements secondary to their disease state. For example, a child with cystic fibrosis who may be admitted to the children's ward with a chest infection for a 14-day treatment antibiotic therapy. These particular children can have an energy requirement of 120 to 150% of what is normal for their age. They need to have access to a system that enables the provision of small, frequent, energy-dense and nutrient-dense meals and snacks. And on top of all that, it needs to be on a what and when wanted basis to maximise their actual intake. In addition to that, the foods provided have to be fat measured and fat calculated so that the family and the child can balance their fat intake against their pancreatic enzyme delivery. Secondly, there's a group of children that have a need for an altered nutrient delivery that actually doesn't reflect a 3-meal-a-day pattern. Where we have a length of stay more than 7 days, we do know that we have a menu fatigue with these children. Children have a loss of appetite. They become institutionalized in respect of the food provision and availability, and also may well have increased nutritional requirements. All of these considerations mean that we need to think about the model of food that we actually deliver to these children. The groups of children that fall into this category tend to be those with cancer diagnoses, cystic fibrosis, head injuries and other neurological conditions, and some of the complex gastro and orthopedic conditions. There's a requirement for these children to have access to a food on a what, when wanted basis, and in other words, at any time of the day, 7 days a week, all the way through the day. And the food that needs to be available needs to meet their very specific requests at a particular time. For example, that we may have a child who we've been coaxing to eat for a number of days, and then all of a sudden at breakfast time they decide they would like a bowl of plain pasta covered in broccoli and grated cheese. We need to be able to provide that. We may well have a child, the cystic fibrosis child we mentioned, who again was struggling to be able to provide food for them and something that they will actually eat. But at 3 o'clock in the afternoon, they decide they would like a small piece of pizza. We need to be able to provide it. Or indeed, the requirement from any child at 4 o'clock in the morning that now they're suddenly going to eat something and they'd like a tin of Heinz soup from the pantry. We need to be in a position to be able to provide these sorts of things for whatever these children are asking for. The third group that I'd like to address in this category is the need for a textured modified diet. And this is a very much overlooked area of care that is actually principally the remit of our speech and language therapy colleagues. These are a range of available foods that we need either for babies for normal development of their weaning from 6 to 12 months. At the moment, NHS Supplies does not have a supply chain facility for us to purchase baby food, and we're exercising a lot of time trying to actually source baby food into the hospital environment because we are unable from environmental health perspective to use a blender on a ward level. And this also then reaches up to the group of patients that Sophie and her team look after who have dysphagia and sensory feeding issues. These group of patients have a need for foods of different textures that have a nutrient density that is much greater than that normally provided for adults, and they need to be able to meet the specific nutritional requirements for children. Very often they are so high in salt we can't use them, and they also need to meet the International Dysphagic Diet Standardization Initiative, or the IDSI specification for texture modified diets. So that's the group who need altered delivery of nutrients. The final group is the children who are unable to meet their nutritional requirements through normal eating and drinking. And Rob has described a number of these already. This is the cohort of children who require artificial nutrition support. Examples could be those children who simply are unable to eat the amount of food or drink the volume of milk or other fluid that they require to meet their requirements. They could have an inadequate or an absent swallow, or indeed have an altered state of consciousness, such as the child in the PICU environment. We would be delivering that artificial support either as an adjunct to normal eating in the form of nutrient-dense supplements, either in powdered or liquid form, as liquid feeds delivered by a tube, either nasogastrically or orogastrically in the case of a preterm baby, directly into the stomach or jejunum using a surgically placed tube would be another option as well. In situations where the gut is either unavailable or actually it is non-functioning, then we would use what we call, and again Rob has mentioned, the highly complex intravenous nutrition as parenteral nutrition. And we can use a combination of enteral and parenteral nutrition at the same time, not exclusively one with the other. This group of patients for the team here at Addenbrooke can comprise almost 50% of the patient cohort that we manage. I hope that's actually given you a brief summary of the overview of the work of the paediatric dietitian in an acute environment and the challenges that we can face providing food for care. I think in summary, our vision as a dietetic team is for the Children's Hospital or Cambridge Children to be a whole cross-hospital approach to food and nutrient provision. And we see this as an environment where food is considered an integral part of a patient's care and treatment, where children, young people and their families are supported to develop a healthy relationship with food and eating, where food is available 24/7 with facilities that enable patients, their families, staff and visitors to eat together should they choose to do so, and where chefs and the catering team are considered important and much valued members of the clinical team. Thank you.
Thank you, Lynn. And also may I take this opportunity to thank you for all your years of service. There's lots of lovely comments in the chat as well, there might be.
Thank you.
So over to Nancy now. Now, Nancy is going to speak in detail later. So her talk's going to be brief, and then we'll get into the discussion of the panel and the opportunity for comments from the floor. So Nancy, over to you.
Hi everybody, my name's Nancy Bostock. I'm a consultant paediatrician at the Croft Child and Family Unit. I'm just going to very briefly tell you about what I do so that we can go forward with the questions. So the Croft is an under 13s inpatient mental health unit, and we admit up to 8 children and their families at a time with a wide range of difficulties. So the children that we have on the unit have, some of them are admitted with something that's nothing to do with food, but we, as I'm sure you can imagine, the food plays a huge part in our model and in our life on the ward. For all children, what we're trying to do is to help reintegrate them into life. So a lot of the children that come to us, by the time they come to the Croft, they've really restricted their lives for lots of reasons, and so having food together and sharing and being able to attend parties and meals and things that can be really challenging for them for lots of reasons. So we need to food is really essential to their journey of getting better. We do have children that are admitted with specific difficulties with food, and that's a huge range. So children with anorexia, with restrictive eating because of OCD, and someone mentioned in the chat about sensory difficulties and difficulties with interoception, which is your ability to understand the internal, like the internal feelings of your body. So some children might not be able to, they might not experience hunger in the same way, or understand that a feeling that they're feeling is hunger. I mean, it's huge. We also have children that have difficulties with overeating or eating a really restricted diet, and then mood disorders like depression can also impact on how much you eat, and that can be undereating or overeating. And then the other consideration is medications, because we try to limit our prescribing of medications, but medications can increase and decrease your appetite, so we have to think about that too. But food is a massive part of our program and treatment and therapy, and also really important for the social life on the ward and the therapeutic environment, and everyone sharing the experience of food together. And I will talk about that in a bit more detail later, but just to give you a background of what we do. So I think that's probably enough for now, but yeah, please ask any questions.
Fabulous. Well, thank you all to our practitioners for giving a whistle-stop tour about the hugely complex issues that they're dealing with, and the huge team of people, from the chef and the caterers to dietitians to paediatricians and nurses, and I've probably forgotten loads, speech and language therapists, who are working to try and optimize children's nutrition. So we now have just over 10 minutes for a panel discussion. So please, if you have any questions for our panel, please pop them in the chat, and Kathy is going to help me highlight them. Kathy, do we have any questions to start?
Yeah, I think I'm going to turn to Kate Gravitt, who has put a question in the box, but I actually think, Kate, you'd speak to it very articulately. Rob has given you a bit of an answer, but I think it'd be nice for the whole group to hear this elaborated on. So can I call on you, Kate, to just ask that question?
Yeah, sure. Hello. Nice to meet you. Well, I know you, but nice to meet the rest of you. Hello. Yeah, no, I was just considering that obviously I do have one with autism, and my eldest had a brain injury. And one of the things that we noticed quite early on was that there were a lot of aversions around food. And it turned out, after speaking with the speech and language therapist, that there was an interoception situation going on. It was very, very difficult for them to manage food. They didn't know when they were hungry. They didn't know that when they were full. They didn't recognize anything, and found it really, really difficult. This is both of them, actually. And a lot of the time there was a focus on, well, it's behavioral, they're being fussy eaters, and trying to get nutrition into my children so that they can heal, and in my eldest's case recover, was very, very challenging. So I'm wondering how that will be addressed on the ward, and then how that will also feed into the community care that follows, because as you say, it's important in schools as well, and it's very, very challenging. So yeah, that was sort of where my mind was at.
Thank you, Kate. Which of our panel members wants to start with that? Rob, you unmuted?
Yeah, I'm happy to start off. Thanks, Kate. I think as with many of these situations, it can be quite difficult to tease out how much physical, organic contribution there is to the difficulty, and how much psychological, sensory, developmental contribution there is. And I guess that's one of the reasons that there's multiple people involved. And I think one of the things that we hope we're going to be able to deliver better as for the inpatients as part of Cambridge Children's is that earlier collaboration on mental/physical health approaches, so that we don't get too far down the physical route in terms of treatment, intervention, tube feeding, before we cast the net wider and ask for expertise and support, whether that's from dedicated, CCPNR services who understand the range of, complex neuropsychological consequences through to psychology and psychiatry. So I think it's complex. It's complex. The challenge to us is to set up a framework that we can use nimbly for those children who need this type of complex assessment, but to be flexible enough to, give the majority of children a great standard of care, but find ways to provide this sort of integrated approach to those children who need it. Probably not a very useful answer, but
yeah.
That is
very helpful.
Okay.
So thank you, Rob. Nancy, I see you've unmuted. Do you want to?
It's just making me think, looking at the questions in the corner, and I keep looking at them and thinking, oh, I could answer that, and then I think, oh, but Rob could answer that, and Lynn could answer that, and I think it just speaks to how important the integration is, and how much difference it will make, because we're seeing the same difficulties in the Croft and in the hospital. Obviously there's some specifics that are different, but we're seeing so much of the same, and I think that's, Rob, you're so right that the expertise from everybody is really important in helping support children and families.
And I think I would add to that, as someone who, I don't profess to be an expert in nutrition and feeding at all, but in my experience, there's never a purely physical problem or a purely psychological problem. All of us have a constant feedback that varies day to day, minute to minute, let alone month to month, interaction between our psychological state and our physiological state. So you will always need that integration of care, and that's partly why I think this children's hospital is so important and such a really important integration, rather than just co-location, that actually it's teams working together. Do we have any more comments?
Yeah, so I'm going to call on two people. Firstly, Ellis, who's worked in a mental health forensic ward setting for young people. It wasn't a question, but a comment about kitchens, which I think it would be nice to elaborate on a little bit more. And then a question from Debs after that. So Ellis, can I ask you to put your comment to the panel?
Hello, yes, thank you. So I'm actually a PhD researcher as part of the ARC East of England, and this is something when we had these first conversations around that. I was previously a mental health support worker in a forensic mental health hospital for young people, and there were so many problems, and one of them, which had been picked up here, about the flexibility of kitchens to be able to provide food outside of the kind of 8 AM, 12 PM, 5 PM rota, around staff not being able to sit with young people to eat. So it was very much kind of more of a transactional approach rather than a social situation. The young people wanted to do cooking, but there was never the staff members around, the numbers to be able to actually do the cooking with the young people. And when they were able to do it, was massive portion sizes of comfort food, because it was such a unique experience that might happen once a month, and it was a treat to be able to do that rather than a normal everyday activity. So I think I just think this event is fantastic for this, to be able to provide that person-centered approach, the flexibility around each individual's needs and likes and dislikes, and work with that. But I think this really comes from such a logistical aspect around how a hospital functions and how the staffing fits into that, really.
Would any of our panel like to add to that comment? Nancy?
Hi, thank you so much for that comment, and I think you're totally right, and I think it just speaks to how important food is, and how it just goes through everything we do, doesn't it? And and at the Croft, we've got a kitchen, and families make food for their children. And I will talk more about this later, but there is a solution, there is a way round if we are willing to facilitate it. So, and I think that's the whole point of thinking about it now, isn't it, Kathy, to think what we can do to answer these questions. But yeah,
absolutely.
I think,
I think just to mention, so that concept of a treat and the pro-social parts of eating, we in the Mental Health Trust have something called the Darwin Nurseries, which is a place for people with learning difficulties to get a qualification in horticulture. But one of the things we do is always have takeaway fish and chips on a Friday, and it's actually a major focus. It's a point of great excitement. It's surrounded with a kind of ritual, a social ritual, and you know, so I suppose it's Lynne's equivalent to the Burger King in some ways. It's something that people look forward to. It's socially that acceptability that Wendy was talking about earlier today. I just throw that in because the word treat, you know, it's got its function. I'd like Debs now. You've got a question, Debs, for
Kathy, I think Lynn wants to come in.
Sorry, can I just very briefly add as a balance on that side from the acute perspective, that we fully recognise the desire for parents and families to be able to cook and eat together within the hospital environment, and fully support that as something a way we should be looking to move. But I was hoping that the presentation that I gave might give you a bit of flavour of just how challenging that can be from an acute perspective, that we have many parameters that we would need to consider, and certainly I would have sleepless nights at the thought of a parent preparing a meal for a child with celiac disease, putting the knife into the same butter as the parent is providing a sandwich for somebody else, with breadcrumbs on that could actually make that other child extremely unwell. We need to think about how that logistically would work from an acute perspective, and I'm not sure if it actually would, other than on maybe a special occasion basis. And also that the concept of staff and mixing and eating with children and with parents, I fully understand it from the mental health perspective. I absolutely do. But we also need to bear in mind that sometimes staff are caring for very, very sick children, and an opportunity for them to come away from that environment, to relax a little bit and to eat away from parents is actually vital for their well-being. So we need to bear that in mind, I think, when we're trying to balance the mental health and the physical health approach to kitchen provision within the organisation.
As you say, balance, you know, not every meal, perhaps some meals, you know, helpful and perhaps enjoyable for all. Kathy, I think we've got time for one more question.
Yeah, we have Debs, and also actually Isabel has got her hand up, so could we squeeze in too? So Debs, over to you.
Yeah, hi. My experience was obviously from having a child with cancer and on chemo, and I also had a daughter who's diagnosed at 2.5 with type 1 diabetes. So it's very much from a parent's perspective, as to, you know, how do we support the parents? Because obviously when a child has eating issues, and obviously on chemo, that's because of the chemo and the smell and feeling sick, etc. And obviously with Maddie with diabetes, you know, it's really stressful as a parent, but also parents are very capable of exacerbating what is already a massive problem by being stressed around that child, and just you know, a problem that was sort of reasonably minor becoming major. So how do we support the parents?
Rob,
Debs, maybe I can shoot first. I think this, you know, of course applies to many different conditions where we need parent support, and in some ways it's working with parents to understand what they need, but also being mindful of the resources that are available. And I think we as Cambridge Children's have a real opportunity to work with parents right across specialist services to provide the sort of material, and it's likely to be electronic, video-based, you know, this type of forum where people can share ideas and share learning, in a way that doesn't involve one-to-one meetings with professionals, because we simply can't work like that. And so I think we've got to come up with much more innovative ways of sharing knowledge and allowing people to access learning when it suits them in ways that it suits them.
Yes, even parents sort of shared experiences would help another parent, I think.
Yeah. Thanks, Rob.
Can I just mention, we're developing in Tamsin, this is in your domain, a discovery college. Do you want to say a little bit about what that is? Because this sort of education for lots of people who are going through the same thing is something we would be tackling there.
Absolutely. So we have put in a bid for support, but I think there is momentum behind the project. So adult mental health services have for a decade or 2 decades probably actually had recovery colleges, which they provide courses for people to help them keep themselves well and help them deal with various challenges. And these can be anything from a couple of hours to in total, or even shorter, or a video, or to something a bit more intensive, with flexibility about how they're accessed. And the other key aspect is that there's often an element of peer support. Now, there have been a couple in the country that are for young people, but what we are adding to that is we're wanting to make it for all the people who would come to the Children's Hospital in Cambridge, so not just mental health. Obviously, we're starting small, but food and nutrition and support for parents around it would seem to be a key thing to work on. We're doing one about sleep for definite, and it's gone out of my head, the other two that we're hoping to build up as a pilot. And these would be co-produced, and the idea is that parents who had experience to share and wanted to share it would be involved in the delivery. And anything from something, 10-20 minute long video or course that you could log into, or a PDF with some tips, top tips of coping with helping an ill child to eat, for example, to something more intensive for people who are perhaps a little further down their journey and have a bit more time and want to go into things with more depth. I'm aware of time, and I'm aware we've got one more question, and I don't want to eat up coffee too much. So shall we?
We could keep that, it's Isabel Heyman, we could keep that question until after.